Okay, let's get started. A very warm welcome after the summer break to our virtual grand rounds in radiation oncology. You know the format. We aim to present you the latest science presented by the top speakers in a very interactive format. It's a very short session we're going to have, as always. We start at 5 p.m. Central European time, and we have a total of 30 minutes, about 15 minutes dedicated to the presentation of an important clinical trial, practice-changing trial, and then followed by 15 minutes where we give you as participants the opportunity to contribute. So please ask all the questions you would have in the back of your mind. Please use the Q&A functionality of Zoom to ask Professor Umberto Ricardi all the questions you have about this very important trial we're going to present. Reminding you again, this is being endorsed by the Estro Society, Sasra Integro Society. We do not have any industry sponsors to remain completely independent. So thanks to these societies for their support and for their endorsement. Also reminding you that we are recording all the sessions. These are being on our homepage, you can see on the bottom, and this is being linked to YouTube. So all the presentations before are being summarized there. So if you've missed one of these important sessions before, go to our homepage and have a look there. This is the trial we're going to discuss today, a rare event that we're having a randomized trial, phase 3, in a rare tumor entity. It's about primary mediastinal B-cell lymphoma, addressing the question, what is the value of radiotherapy after systemic therapy, after chemotherapy? We know this is a distinct disease. We know that the salvage treatment options are being limited. We know that radiation is effective, but might also be associated with side effects. The primary endpoint has been progression-free survival, and you can see the primary endpoint being illustrated here. And it has just been accepted for publication in the JCO. However, how to interpret this finding, how to translate this finding into your day-to-day clinical practice, this will be discussed by one of the experts in the field of radiotherapy of lymphoma. I'm super proud and honored to have Professor Umberto Ricardi with us today. He is full professor and chairman of the Department for Radiation Oncology at the University of Turin. He's also chair of the Department of Oncology and dean of the School of Medicine at the University of Turin. He's member of the steering committee of the ILROC, and that is where our friendship comes from. He has been former president of the Estro Society, and obviously has been deeply involved in the design, in the analysis and interpretation of this trial. Umberto, we are very honest and grateful of having you here. We're looking forward to the presentation and discussion of the results. Thanks for being here today with us.
Thank you very much, Professor Guckenberger or Matthias. Thank you very much indeed for the very important privilege you gave me in sharing with this virtual community. I mean, some consideration, sharing my screen right now. Okay, as I was saying, it's really a great pleasure, and thanks again to you, to the University Hospital Zurich for this opportunity. It's a pleasure for me, and thanks to all of you for attending this webinar to share with you some consideration regarding the role of radiotherapy in primary mediastinal B-cell lymphoma. Of course, focusing, as Matthias said, on these recently published or accepted, I mean, almost published in the complete form on JCO, phase 3 prospective trial evaluating the contribution of radiotherapy as a consolidation in patients receiving chemoimmunotherapy and achieving a complete metabolic response at the end of chemotherapy when affected with primary mediastinal B-cell lymphoma. Of course, I guess that you are familiar with this tumor entity. For sure, this is a very rare tumor because it represents roughly 5–6% of the total of NHL. Is a extranodal lymphoma, since the origin of the disease is from a thymic region. This primary B-cell lymphoma has a specific immunophenotype, for example, with CD30 positivity in the vast majority of cases. Also, in terms of gene expression profile, this tumor entity has a specific characteristics. From the clinical point of view, it's an aggressive disease with important clinical symptoms at presentation due to the bulky disease. But in spite of this clinical aggressiveness, the therapeutic possibilities are quite good. You can see how using the classical treatment represented by a combination of systemic treatment and consolidation radiotherapy to the mediastinum, you can achieve important positive results with progression-free survival rates in the range of 85–90%. Unfortunately, for the few patients with a refractory disease or with a recurrent disease, salvage treatment possibilities are very limited, even if very recently in the era of CAR T-cell therapy, we can slightly increase these salvage possibilities. If we look at the information in the literature, you can see, this kind of information based on mainly retrospective studies, because classically, and you can see at the US National Cancer Database series, you see how the combined modality therapy can achieve better results compared to systemic therapy alone. And as I said, the classical treatment was represented by a combination of systemic treatments, chemotherapy before, more recently immunochemotherapy, meaning rituximab plus chemotherapy, followed by consolidation radiotherapy. Even if, roughly 10 years ago, we had this important phase 2 clinical trial from National Cancer Institute and MD Anderson in Houston, where you can see how on 51 patients using an aggressive chemotherapy regimen without radiotherapy, the final results were really very, very good, with more than 95% of patients cured with the chemo only, without consolidation radiotherapy. This kind of information brought the North American community to forget consolidation radiotherapy since some years, even if, of course, we don't have, a phase 3 randomized clinical trial. We didn't have until now phase 3 information supporting this kind of choice. You can see here also on the SEER analysis how, again, the combined modality therapy can guarantee better results in terms of overall survival compared to chemo only. But in spite of these different clinical outcomes, you see how there is a decline, and there was a decline across the years in the use of consolidation radiotherapy. Even before 2013, which was the year of publication of the paper I mentioned you before. And this tendency is, very important, not only in North America, but also in Europe, in spite of the lack of randomized clinical trials information. If we look at Europe right now, you see this subgroup analysis from this German trial that was dedicated to nodal non-Hodgkin lymphoma, nodal aggressive non-Hodgkin lymphoma. But looking at this subgroup analysis of 131 patients affected with primary mediastinal B-cell lymphoma, you can see here the final randomization, meaning radiotherapy versus no radiotherapy in patient achieving complete response at the end of chemotherapy. There was, again, a superiority in terms of clinical outcome due to the contribution of radiotherapy compared to chemo alone. So once again, in this case, we can confirm the utility and the efficacy of consolidation radiotherapy in the recent years. But of course, we have right now a new tool, so a new elephant in the room, meaning the possibility to increase our possibility to confirm the achievement of a better, let's say, clinical response evaluation. Because of course, using functional imaging, and so the PET scan for stage disease at the end of chemotherapy, we can probably better select the patients really in complete response compared to the previous information based only on morphological imaging. So the issue is this one, using a PET scan at the end of therapy, and so confirming a status of metabolic complete response. The question is a negative PET scan at the end of therapy a reliable indicator of cure following immunochemo alone making consolidation radiotherapy not necessary. And so from this point of view, in the era of PET restaging, we have some retrospective information. This is an Italian experience from Bologna University, Pierluigi Zenzani, showing you how in patients achieving PET negativity at the end of modern immunochemotherapy, rituximab plus third generation chemotherapy like this MACOP-B regimen, you see how without radiotherapy you can get more than 90% of progression-free survival rate. Similarly, from Canada, Vancouver, British Columbia from Vancouver, you see two different eras. The traditional one, so 2001, 2005, routine consolidated radiotherapy, irrespective of the restaging of this patient, and more recently, in the PET era, the possibility to omit radiotherapy in patients achieving complete metabolic response, you see similar outcome between the two eras, meaning the possibility to significantly reduce the use of radiotherapy in the routine clinical setting. But once again, these are only retrospective evaluation. So putting all these food together, there was for sure a necessity to produce, phase 3 clinical trial results information. And that was the reason for which, in 2010, we started a discussion within this international extranodal lymphoma study group in terms of a phase 3 clinical trial evaluating the contribution of radiotherapy, yes or not, in patients achieving a complete metabolic response after standard immunochemotherapy. The aim of the study was, of course, the possibility to test whether mediastinal radiotherapy could be safely omitted in patients achieving complete metabolic response, with the primary endpoint represented by the progression-free survival at 30 months from randomization, and as a secondary endpoints, the overall survival figures at 5 years and the late toxicity. This is the trial design. You see registration of the patient, standard immunochemotherapy, of course, considering the international cooperation for such a rare entity as mandatory. Of course, several chemotherapy regimens were admitted. You see R-CHOP21, R-CHOP14, R-CHOP, dose-adjusted epoch, R-MACOP-B, R-MACOP-B. In spite of course, the different chemoimmunotherapy regimen in patients achieving a PET negativity with central review of this PET scan, in patients with PET negativity evaluated at 5-6 weeks after the end of chemotherapy, the randomization 1-to-1, mediastinal radiotherapy, so the standard arm, 30 gray in 15 fraction, versus no further therapy, so observation as the experimental arm. The reason for which we consider the Deauville score 1, 2, and 3 as negative was based on the previous trial, 26 from the International Extranodal Lymphoma Study Group, because in that trial we showed that FDG uptake below liver cutoff, so Deauville score 1, 2, and 3, were able to better discriminate patients considered different risk of relapse after systemic treatment. So these Deauville score 1, 2, and 3 were considered as negative, and so allowing us to omit radiotherapy in the context of this randomized clinical question. The statistical assumptions were to consider this trial as a non-inferiority trial, imaging a 85% progression-free survival probability for both arms, and considering a 10% as a delta difference in the observation arm in terms of non-inferiority trial. This methodological evaluation brought us to consider the number of patients to be enrolled for the randomization as the total number of 540. Of course, expecting a PET negativity at the end of a chemotherapy in the range of 70%. We had different interim analysis with 2 planned interim analysis and 1 unplanned interim analysis with the International Data Monitoring Committee evaluating an important and of course a positive consideration represented by the lower number of events. So the number of events were lower than expected. And of course, this brought the International Data Monitoring Committee, of course, to imaging a completely modification of the number of patients, showing you how the original design had to be considered unfeasible in terms of lower events in this entity. And so the data monitoring committee recommended at this time not to increase the study size and duration to meet the planned non-inferiority margins, to complete the planned accrual of 540 patients, to perform data analysis for primary endpoint after a minimum follow-up of 30 months for more than 80% of patients, and of course to include in the final analysis the absolute difference between the two arms. These are the number of patients recruited. You see this huge international commitment with a very good cooperation at the worldwide level. Of course, Italy was very active in recruiting in the context of an Italian lymphoma group, a significant number of patients, but the cooperation was very good at the international level. And these are the figures of the patients. You see 545 patients enrolled. The difference compared to the original estimation was a 50% of PET negativity at the end of chemoimmunotherapy compared to the originally expected 70% of negativity. And you see, so 268 patients with PET negativity randomized in case of 1, 2, 3 Deauville score. And so you see 132 observation and 136 patients receiving consolidation radiotherapy. In terms of clinical characteristics between the two groups, you see here, of course, a significant prevalence of younger women, because this is a disease, typically of young women. The median age was 35 years. You don't see significant differences in terms of clinical characteristics between the two arms. And of course, the vast majority of patients had bulky disease with tumors larger than 10 centimeters and with an elevated LDH values. In terms of chemotherapy regimen, the most commonly used were R-CHOP14 and R-MACO-B, R-VACO-B. From this point of view, no significant differences among the different chemoimmunotherapy regimens, apart a worse outcome for R-CHOP21. We know right now that, of course, we don't have to use R-CHOP21, so every 3 weeks for primary mediastinal B-cell lymphoma. From the radiation therapy point of view, you see these analyses on 120 patients out of 136, modern radiotherapy in the vast majority of cases, with more than 70% of patients receiving intensity modulated radiotherapy. You see the most typical fractionation was 2 gray daily fractions. From follow-up duration, as requested by the data monitoring committee, you see that, of course, we published the results when more than 90% of patients, more than 95% of patients achieved more than 30 months of follow-up. And the median follow-up for both arms is in the range of 5 years. So considering the type of the disease, is certainly a good follow-up time. And here are the curves. You see the progression-free survival curves. Progression-free survival was the primary endpoint without significant difference between the two arms, 96%, 98%. So progression-free survival quite similar. In terms of stratified analysis, you see an absolute difference between radiotherapy and observation in the range of 1%, so 1.2%. Meaning that, of course, theoretically, you had to treat more than 100 patients to avoid one single relapse. So certainly no significant difference between the two arms. And also in terms of other methodological evaluation, you see that this trial had a statistical power of more than 85%. In terms of a possibility to detect an absolute progression-free survival difference at 30 months superior to 6%. Overall survival was one of the 2 secondary endpoints. You see, of course, no difference from this point of view. Excellent clinical outcome in terms of overall survival for such an aggressive disease. So the conclusions of the trial. First of all, of course, as you know, this ISLG 37 is the largest randomized trial of primary mediastinal B-cell lymphoma. Of course, still to remember that this is a rare tumor. So international cooperation was the key to achieve, these numbers and to have the possibility to perform a phase 3 randomized trial. The conclusion is that mediastinal radiotherapy can be safely omitted in patients achieving complete metabolic response, so the score 1, 2, 3, at the end of immune chemotherapy. And this is in line with the retrospective study I mentioned you before. In terms of toxicity, so far, 3 severe cardiac events and 3 second cancer have been reported, all in patients randomized to radiotherapy arm. Of course, a longer follow-up is certainly needed to better evaluate late toxicity, but in terms of events, I have to share with you that, of course, in terms of cardiac events, as you see here, the first of this event was certainly in a patient randomized to radiotherapy arm, but in the chemotherapy phase. So radiotherapy, of course, doesn't have any role. In terms of second cancer, you see metastatic melanoma, glioblastoma, and acute myeloid leukemia. So difficult to say that mediastinal radiotherapy might have a role in this second cancer number. So to conclude my presentation for the final 3 minutes, so just to mention with you something regarding this part of the trial. So the contribution of radiotherapy in patients not achieving a complete metabolic response. So the PET positive patient, DOV score 4, DOV score 5 patients. Meaning, of course, the possibility to consider these limited positive uptakes at the end of our chemotherapy as part of our therapeutic evaluation. In the vast majority of these patients, of course, radiotherapy represented the standard treatment. You see here that in patients affected with DOV score 4 at the end of chemoimmunotherapy, 148 out of 163, so 91%, received consolidation radiotherapy as a standard treatment. And you see here how the clinical outcome of patients receiving radiotherapy alone in case of DOV score 4 was very, very good. Outcome similar to those with DOV score 1, 2, 3 treated with chemo alone. The outcome of patients with a DOV score 5 at the end of chemotherapy are certainly suboptimal, and so certainly needing further therapeutic possibilities. We published, some time ago, the same results in our Turing series, 51 patients, showing again the possibility of radiotherapy in patients with DOV score 4 at the end of chemotherapy are quite good. You see, 0 relapse out of 17 patients with DOV score 4. So radiotherapy is certainly an important piece of the therapeutic package in patients not achieving a complete metabolic response, like also reported by the previous ESLG trial, showing you how efficacy can be radiotherapy on this small uptake. So for that reason, in spite of sharing with you the presentation of this JCO paper showing the possibility to omit radiotherapy in patients affected with primary mediastinal B-cell lymphoma, my conclusion is that radiotherapy can certainly still have a role in primary mediastinal B-cell lymphoma because, first of all, only 50% of patients achieve a complete metabolic response after immunochemotherapy. And radiotherapy is highly affected in the other patients in converting them to complete metabolic response. We can certainly have some issues in terms of interpretation of some DOV score findings. We can certainly have some false positive findings from this point of view. But of course, the risk to omit radiotherapy in this case is quite important because, as I said at the beginning, the salvage therapeutic possibilities in patients relapsing in such a disease are certainly very, very limited. It is certainly true that we need a new imaging criteria for response evaluation at the end of therapy. And so some PET metrics, for example, the submax, or liquid biopsies, for example, ctDNA, can certainly represent the possibility on which to build a future trial. And this is one slide showing you from MD Anderson, like in patients with DOV score 4, DOV score 5 at the end of chemoimmunotherapy, the possibility of identifying a SU value superior to 5 can certainly influence the clinical outcome. And these information are exactly the same from Toronto, Princess Margaret Hospital. You see here how SUV maximum more superior or inferior to 5 can certainly influence the clinical outcome of the patient. Finally, of course, in relapsing patients, in spite of the therapeutic possibilities of systemic treatment, of course, radiotherapy can certainly have a role, including the possibility to consider radiotherapy in the peri-CAR T scenario in patients receiving this procedure. And this is the last slide, just to thank, of course, different people, especially starting from the 3 PI of the study, Emanuele Zucca from Bellinzona, Maurizio Martelli from Rome, and Andrew Davis from Southampton, UK. So thank you again, and thanks, Matthias, again for this very pleasant opportunity.
Many thanks, Umberto. That was a fantastic presentation in an introduction presentation of the important trials and also of your interpretation. We have a couple of questions. May I start with one? I mean, your recommendation was quite clear that despite all the kind of statistical issues with the kind of higher or lower complete metabolic response rate, with the kind of much better progression-free survival than observed, you would say that in patients having a complete metabolic response, DS1 to 3, that there's no role for radiation. How precisely can we define metabolic complete response in day-to-day routine? When I was reading the study, I mean, there was quite an elaborated panel assessing metabolic response on the PET imaging. So what is the accuracy in distinguishing between complete and incomplete metabolic response in daily routine without having these expert panels?
That's a very good question, of course, and it's a question that I always share with our friends from the nuclear medicine community, because, of course, when we perform clinical trials, we continue to request a sort of a central review process for PET evaluation, while very often, at least in our country, in the routine clinical activity, not only in primary mediastinal B-cell lymphoma, but also in Hodgkin lymphoma, for example, or in other hematological malignancies, there is a tendency to use PET scan information without this central review process. So I guess that, of course, after several years in using within the nuclear medicine community this kind of information, the possibility to, let's say, to have a good reproducibility of these results is certainly better compared to the past. But I mean, when you use, I mean, de-escalation, let's say, strategies, for example, it's certainly better to imagine, I mean, this process in the context of central review activities. So very often it's very hard to admit that in the routine clinical work, we can base our therapeutic choices on these, let's say, clinical information.
So if you have a patient case which is just between DS3 and DS4, would you make a case to kind of go for mediastinal radiotherapy, or would you feel confident enough based on the results you've shown for the DS4 cohort, which have not been randomized, to also kind of opt for an observation in these borderline cases?
No, I guess that in spite of our professional bias, meaning a radiation oncologist jacket, but I guess that in case of doubts between DOVI score 3, DOVI score 4, there is no reason to omit modern radiotherapy, because of course we have to consider that modern radiotherapy is certainly very good in reducing the risk of late toxicity compared to what we produced, I mean, a couple of decades ago with, let's say, rudimental radiotherapy compared to the current possibilities. So that's the issue I always discuss with our hematologist friends. I mean, saying them that, of course, guys, if we have a relapse in such a disease, of course, unfortunately, we can lose the patient, while modern radiotherapy is able to reduce the risk of significant late toxicity compared to the past.
We have some more questions here. One is coming from Joachim Wilner. Thanks for joining and being here again. Are there differences in subtypes of lymphoma?
I mean, if the question is, I mean, a comparison between a primary mediastinal B-cell lymphoma versus other aggressive non-Hodgkin lymphoma, like the classical nodal aggressive lymphoma, of course, in localized aggressive lymphoma, the issue is a comparison between a more limited amount of R chemotherapy plus radiotherapy, so combined modality therapy, versus more chemoimmunotherapy alone. And so at the moment, we don't have, of course, randomized, phase 3 randomized study information for, let's say, doing that kind of choice. It's again a discussion from clinical point of view in terms of risk based on more chemotherapy from one side compared to less chemotherapy and radiotherapy, depending on the anatomical site. So treating with the radiation a groin is nothing compared to a mediastinal disease, for example, of course. If I correctly interpreted the question, I guess the anatomical subtypes, the lymphoma subtype difference, meaning aggressive lymphoma compared to mediastinal B-cell lymphoma. In case of Hodgkin lymphoma, of course, we know in a case of, let's say, advanced disease, meaning more chemotherapy, that the contribution of radiotherapy is, probably very, very limited. So similar consideration to which I share with you on primary mediastinal B-cell lymphoma.
There's another question, a couple of questions about patients having DS5, so kind of poor metabolic response. Where is the progression pattern in these patients? Where was it in the trial? Was it mediastinal again? And the second question was, what is the dose you would say is appropriate in these DS5 patients? 30 gray or 36 to 45 gray? Thanks for EH Guest and Andreas Gretenschläger.
Yeah, thanks also from my side for these very interesting questions. In case of the OB score 5, very often the OB score 5 means also a limited response in terms of a morphological evaluation, not only in terms of metabolic information. And so in the vast majority of cases, the residual disease or the relapses are completely local. So infield disease, meaning a true or refractory characteristics of this disease. In terms of dose, of course, in case of the B score 5, we certainly use more than 30 gray, so 36 or 40 gray is the classical dose we use in this trial.
And maybe a final question. Can we omit radiotherapy in mediastinal diffuse large B-cell lymphoma patient in analogy to the studies of primary mediastinal B-cell lymphoma?
In case of, let's say, 6R CHOP, aggressive lymphoma with mediastinal presentation, I guess that based on these results, we can do that. Even, of course, if primary mediastinal B-cell lymphoma is a completely different disease from different points of view, compared to, let's say, aggressive lymphoma. So primary mediastinal B-cell lymphoma is more closer to Hodgkin lymphoma than aggressive lymphoma. So once again, aggressive lymphoma, nodal aggressive lymphoma are not so common in terms of bulky mediastinal disease. We have more abdominal bulky presentation rather than mediastinal disease. But once again, I guess that based on these results, we can certainly discuss in the tumor board the possibility to safely omit radiotherapy also in that arena.
Well, I don't see any further questions. We are perfectly on time. So many, many thanks to you again, Umberto, for this excellent presentation and discussing. Thanks everyone for participating in a virtual grand round, which was today focusing on a more rare disease, not breast, not prostate, but lung cancer. But it's very important to kind of also keep in mind that radiotherapy is still and will remain an important component in multimodality treatment, not only in lung, not only in breast, but also in lymphoma patients. So many thanks for joining. Wishing everyone a good afternoon. Hopefully it's warm outside. You will enjoy the last sunshine in the autumn and summertime. See you at the next virtual grand rounds. We will, as always, announce them on the social media and on our homepage. Have a good time, everyone. Bye-bye.
Thank you again. Thank you, Ray.